Hi there, I'm Dr. Leah Light from the Brainchild Institute. Today I'm going to talk to you about one of the more common types of auditory processing disorders. It's recently been called amblyaudia. Now, similar to the lazy eye syndrome of amblyopia, amblyaudia sort of follows in the same vein in that it isn't really that the child has a hearing loss in one ear, it's just that the processing from one ear is weaker than the other side, and it creates a host of learning problems and behavioral problems as well. So I hope you enjoy this presentation, and let's move forward. So what is amblyaudia? Well, as I mentioned, it is one of the most prevalent types of central auditory processing disorder, or CAPD, and it's noted in children ages 7 and older. It's also been referred to for many years as an auditory integration deficit. It occurs when the two hemispheres of the brain do not communicate well together. Amblyaudia leads to learning, social, attention, and behavioral problems. It also interferes with the understanding of the combination of verbal and nonverbal speech cues. So this is a schematic that I borrowed from Terry Bellis's book, When the Brain Can't Hear, which is an excellent book regarding auditory processing disorders. It was written a number of years ago. But I like this picture. It's very simple and it's easy to understand. Let me explain to you a little bit how this works. So when sound information comes into the ears, it's first routed to the inner ear, which we refer to as the cochlea. And assuming that everything is working well up to that point, the middle ears work well, the ossicular chain is conducting this sound stimulation and vibration appropriately, and that the hair cells of the inner ear are working well, then the information is then transferred up the hearing nerve, the eight nerves, to the brainstem, the lower part of the brain, where the process of auditory processing begins. Down there at the very bottom of the drawing, where you see the little face, is a box, and you'll notice the words in there: where, when, loudness, pitch, and timing. These are more functions of the lower brain or brainstem. And as little babies, we begin to localize sounds, looking left and right for sounds at about 6 months of age. We start to localize earlier than that, but really clear head turning on a horizontal plane occurs around 6 months of age, and looking up and down for sounds maybe 9-10 months of age. And so the brainstem is helping us to understand what direction sound is coming from, how loud it is, based on characteristics between the two ears and the head. And then after the information passes through the brainstem, it travels to higher levels of the brain. The information crosses over from one ear to the opposite hemisphere of the brain. So the dominant pathways in hearing are very similar to the dominant pathways in motor skills. A little bit of information, as you can see from the dashed lines that go from the cochlea there up to the temporal lobes, a little bit of information is going to trickle up to the same side, same hemisphere, but the dominant pathways for hearing are contralateral or crossed. So if I were to put a signal into the right ear, it would go to the left side of the brain first. And if I put a signal into the left ear, it would go into the right side of the brain first. And between the two hemispheres is a bridge, a large wiry tract that we call the corpus callosum. And the corpus callosum is a very, very important structure. And when we're born, it's largely unmyelinated. And myelin, you may recall, is a fatty coating on the nerve sheath that makes information travel faster and more efficiently. And around age 10 or 11, the corpus callosum becomes close to an adult-like corpus callosum, and it becomes largely myelinated, so that by the time we're 10 or 11, our auditory processing skills should begin to approximate adult values. Each side of the brain, though, has different functions, And I want to talk about these a little bit to help you understand what's going on in amblyaudia and why children are having the types of learning problems that they're having. So on the right side of the brain, if you look where it says right temporal lobe, there's a kind of rectangular tall box there where it says on the right side of the brain is where we perceive intonation, so the tone of somebody's voice. It's very intuitive, the right side of the brain. It is more about novelty. It likes to do things in different ways, newness. It pays attention to emphasis that we place on certain things, as we're saying, you know, do it now, or we say do it now. The rate at which we speak, how fast we say it, how we say basically what we say. It's more musical, more involved in nature sounds, processing of nature sounds and animal sounds, more in tune with understanding our emotions, like when we emote certain sounds like it's also involved in danger and warning sounds. Right hemisphere is more involved with safety and non-linear processing. It's also more involved in our vestibular processing. So the right hemisphere has more representation of our body and space, and it's more now oriented, what is happening right now as opposed to something that happened yesterday or something that's about to happen. And we believe that it may respond more to lower frequency sounds because of the fact that the vestibular system responds better to low frequency information. On the left side of the brain are a host of different functions. This side of the brain is our speech side of the brain. At least it is for probably over 96% of individuals. So most of us have our speech and language centers on the left side of the brain. It's more involved in repetition. It likes to do the same thing over and over and over. Don't change my pattern. It likes that sameness. It's very interested in what is going on, what exactly is going on, and which one of these is it, and who is it. It's more interested in precision, if you will, and specifics of information, details. And, you know, those individuals who sort of lose the forest because they're stuck looking at the tree may be a little bit more left brain oriented. Digital information, so when we're paying attention to our cell phones and our laptops and so forth, this digital information is more processed on the left side of the brain. It's our analytical brain. It's much more involved in academics. It is a linear processor. It likes things to happen in a particular sequence or order. It's very reflective, looking back, futuristic, looking forward, and we believe that it may respond or process high-frequency information a little bit more differently than the right side of the brain, because high-frequency information in speech carries the more specific features of speech that help define speech and give it clarity. So what are some of the symptoms of this condition, this amblyaudia, that children might display? And I'm speaking about children, but yet adults may also have these problems. Well, their feelings are often hurt. They often feel like people are mistreating them or picking on them. They don't understand certain types of social nuances. They may misunderstand what is meant by what is said. They frequently say things like, I don't get it. And I often refer to them as the I don't get it kids, because that's what they say. They hear you, but they simply don't get what you want them to do. They must be shown things over and over and over before it sticks. It almost seems like sometimes you just showed it to them and they're looking at it as though they've never seen it. They may behave very immaturely and have a tendency to engage with younger children whose brains are probably at the same stage of development as theirs. Frequently, they have loudness sensitivity issues and they hold their ears for certain sounds, and they often are reporting that they are having trouble hearing in background noise. These kids have trouble understanding sarcasm, humor, as I mentioned, and idiomatic expressions. They tend to have difficulty in school with reading comprehension, though their word attack skills may still be well developed. So in other words, they may be able to read, Johnny rode his bike across the street, and you say to them, wow, that was so fluent. What was that sentence about? And they say, I don't know, let me read it again. So they have trouble integrating visual and verbal speech signals. And they have trouble with math word problems for the same reasons. They may be able to perform math computations quite well, but have a lot of difficulty visualizing the spoken information, such as, Susie has 3 apples and Johnny gives her 2 more. How many does she have in all? Many people ask me, many parents ask me, well, what happened? Where did I go wrong? And it may not have anything to do with where the parent went wrong. Some of these problems could be hereditary, but quite honestly, the causes of amblyaudia are not clearly defined. These individuals often have a history of sensory processing issues. They may continue to have sensory processing issues. Maybe they've been to an OT before, occupational therapist, to address their sensory processing issues, and yet these auditory pieces still remain. Sometimes these children have skipped some developmental stage. For example, when children skip crawling or crawl for a short time or crawl in a very unusual manner, I very often will see that child that will have some auditory integration deficit, or amblyaudia as we're now calling it. Many of these kids too also had early histories of middle ear disease, and even the middle ear disease can influence their motor coordination skills and cause them to maybe skip a developmental milestone. So it may be a case of what comes first, the chicken or the egg. In addition, these kids have more trouble than most children crossing midline, being able to reach across their body and know even that they have 2 sides of the body and how to work the 2 sides together. They often also have retained primary reflexes, and in particular, we see many of these children with retained ATNR and STNR reflexes, and we'll talk more about those in just a moment. Oh, here we go. So the ATNR, or asymmetrical tonic neck reflex, you can Google these and you'll come up with a lot of information. And even if you Google retained primary reflexes and learning disabilities, you'll find quite a bit of information. Although I will say that even though there's a lot of research to support that there is a link between retained primary reflexes and higher level development, the studies that conclusively show that doing reflex integration exercises definitively improves learning abilities has not yet been clearly shown. Anyway, with the ATNR, the baby turns his head to one side, as you see the little baby in the picture here, and that causes the side that the baby is facing towards to straighten or extend, and the opposite side will bend. And integration of this particular reflex usually occurs by about 6 months of age. Most primary reflexes are integrated within the first 6 to 12 months of life, and they are replaced by postural reflexes, or more deliberate movements, so we're not just reactive all the time. And this is necessary for understanding the body midline across the y-axis for left and right differentiation. So as that baby turns to one side and one side straightens and the other side flexes, and then the baby turns to the opposite side and now the opposite side straightens and the other side flexes, they start to develop a sense of where midline is so that they can learn about left and right. Children where the ATNR is not integrated will often have a lot of confusion about left and right, and these children may have trouble even with writing and knowing that the letter P, the loop goes on the right side of the stick, of the vertical stick, and the letter Q goes on the left side. But a lot of this starts from just understanding your own body position in space. When children are in this ATNR position, they are activating their hearing on the side where the head is turned. And so unilateral hearing becomes activated, and the vestibular system is also activated on that side. And also ATNR helps us with development of eye-hand coordination. The little girl that you see on the right side of the screen is holding her arms out, and she's looking over her right shoulder. And there's a little caption underneath there. I borrowed this from selflearningdisabilities.com, this picture, that the little girl is able to hold her arms straight in front of her body and move her head to the right without her arms turning towards the right. And when this happens, we know that the ATNR reflex is integrated. One thing I encourage parents and teachers to do is to take a look at their own children, look at some of the kids that they're working with or in their family, and run this particular test. It's very telling. It will give you a lot of information about whether this reflex is present. And if it is present, some of the things that I've just said will start to make sense. So the little test is called a Schilder test for the ATNR. And very simply, unfortunately, I'm doing my own recording over here, so it's hard for me to show you this. So I'm going to do my best to explain it to you. Just like the little girl in the previous picture, the child stands with both of their arms extended in front of their body. Their arms are shoulder height and their hands are relaxed, so they're not flexed. Let's see if I can get my hands there. Okay, good. And the examiner says to them, keep your arms in front of your body, and I'm going to just move your head from one side to the other, and you keep your arms right there where they're at, right in front of your body. And you turn the head gently to the right side, so the child's looking basically towards the right shoulder. And the hands, you're noticing if there's any change in the arm position, arm movements. Do the arms move to the same side where the head is turned? Or do the arms drop down, straight down? And then you're going to repeat this procedure on the other side. And as you turn that head, you're going to keep the head there for maybe, 5 to 10 seconds just to see what happens with the arms. If the arms move 45 degrees or greater to either side or downward, as I mentioned, the ATNR is still present. It has not been integrated, and it will likely affect reading and other academic skills. It will also interfere with certain motor skills as well. I have included a little link there if you can see it or you want to get to it, a YouTube link if you want to see the Schilder test done. The other very important reflex that contributes to all types of learning problems, including amblyaudia, is the symmetrical tonic neck reflex, or STNR. What happens is that movement of the child's head causes the arms and legs to bend or straighten when we're infants. And this is usually happening around the time the baby's getting ready to crawl or crawling. This is around 9 to 10 months of age. When the head goes down, as you see in the middle picture, the arms bend and the legs straighten. And when the head goes up, as you see in the top picture to the right, the arms straighten and the legs bend. And so head movement in a vertical plane is directly linked to arm and leg movements. When this is poorly integrated, we see abnormalities in bone structure, very often in the arms, and we see poor weight bearing on the hands. But even more importantly, these children will have difficulty integrating information from both eyes and both ears simultaneously. If you think about it like an animal that's listening in the woods, you see that they have a they're leaning forward, their posture is very straight, we call that trunk extension. Their eyes are forward, their ears are forward, and they are focused on some very specific thing in the distance. And the STNR helps us to be able to develop these higher levels of binocular vision and binaural hearing. Now, one way to test for it, and you can't see it very well because I see my pictures in the way, but is to just simply put the child down on all fours as though they're about to crawl, and ask them to lift their head up and then lower their head down. And what you're looking for is there any arm movement? Do they bend their arms when they look down? When they look up, do they sit back on their heels like the baby in the first top picture? If there is any movement of the body or the limbs as the head is moved up or down, then this reflex is not integrated, and it really needs to be addressed before other higher levels of learning are going to be able to be accomplished. Here is a picture of a young man who has an orthopedic problem as a result of a retained STNR. And you'll notice how the elbows are almost inverted, and we see this on a number of our children. One of the reasons why the STNR is also so important is that it can interfere with a child's ability to stay seated and to focus and see information on the board and copy it onto their paper and look far away and look near, and it interferes with their ability to feel comfortable in their own bodies. Many times when the child looks up, the arms will extend and the legs will bend. If the child looks down, the arms bend and then the legs straighten. So the child sometimes when he looks down at his paper, he wants to stand up because his arms bend and his legs want to extend. So you can very often see these children hooking their feet around the chair legs, trying to stay in the chair. Children with a retained ATNR, you'll see them because they will be the child who is lying down on the table while trying to write. As the head goes to one side, the arm wants to straighten on that side, and the opposite side it bends. And so all of these automatisms are interfering with the child's ability to carry out these academic tasks, and because they're having to use all these adaptations, they're fatigued and they have less resources to get other types of learning done. Another thing I like to do is a little screening to flag a child that might be at risk for Amblyaudia. So we have the Schilder test for ATNR, we have the in the crawling position with head up and down for the STNR, but I like to do cross-crawl checks. These pictures are courtesy of Brain Gym, where the child has to tap their hand to their opposite knee and see if they can do that readily. I don't say to them, tap your opposite knee. I just say to them, can you do this? And I model tapping my right hand to my left knee and my left hand to my right knee and so forth. I also like to look at, can you do this? And tapping the opposite side of my head. So we call those cross brain taps. We do cross eye taps. Can you do this? Where I cross over and I touch the opposite eye with my opposite hand. Can you do this? And I do this with my ears. I know you can't see me very well, but I'm touching my opposite hand to my opposite ear. And then we have them draw something that Brain Gym refers to as infinity eights. And that's the little girl on the bottom left there you see in this picture, where she's drawing an infinity sign. Many of these children you'll see will draw something that sort of looks like a peanut shape, but they can't cross the midline. And by the age of 7, I'm really expecting these infinity eights to be very easy for the kids. I'm not interested, I know they can draw a vertical 8, but I want to see if they can draw this horizontal 8. It tells me a lot about whether this particular area of the corpus callosum, where vision and auditory information cross back and forth from one hemisphere to the other, it's called the splenium. It's the posterior 1/3 of the corpus callosum. Whether this is matured or underdeveloped. So by age 7, they should easily be able to draw that infinity 8. Now, how do audiologists test for amblyaudia? Well, mostly we use something called dichotic listening tests. And these particular tests, now I'm higher up in the brain. Remember, motor skills develop first, and then these higher level processing skills develop later. If the motor skills are not well developed, they're going to lead to a garden variety of different types of learning problems, where the child may have very uneven learning, may be very good at certain tasks and very poor at others. So we use for the auditory processing a type of test called a dichotic listening test. And what we often see is something called a left ear weakness. So when you look at that diagram again, I've added the word speech on the left side of the brain because most of us have our speech centers on the left side. So that if I put two words in the ears at the same time, for example, if I put the word car into the right ear and shoe into the left ear simultaneously, both words want to go to the left side of the brain where that little speech box is in your picture. And I already mentioned that the cross pathways are dominant in terms of auditory processing. So the word in the right ear crosses across the brainstem and goes to the left hemisphere to the speech center, and it is easily processed. It's sort of a straight shot. But the word in the left ear, first, you follow the little yellow tract, if you will, there, has to go from that left ear across to the right temporal lobe, and then looks around and says, hey, wait a minute, there's no speech center here. I have to go back. So now it has to go across the corpus callosum, back to the left temporal lobe in order to be processed. So our left ear actually has a longer way to travel in order for speech information to be processed. And hence we see a left ear weakness, especially if the corpus callosum is underdeveloped or immature. And that corpus callosum, as it becomes more developed and more myelinated, information travels more rapidly across the corpus callosum, and it becomes a slick superhighway. But when it's underdeveloped, it's like a little bumpy road, and information just kind of bumps along, and we're lucky if it even makes it across the corpus callosum to begin with. So many of these children will tell me when I do a dichotic listening test with them that the right ear is louder when both ears are at the same volume, but their perception is that it's louder because the right ear actually is getting to the speech center ahead of the left ear, and it's processed as being louder, but it's really a timing issue. Now, how do we treat amblyaudia? So we know how to test for it, but how do we actually treat for it? My top bullet, if you can read it, says primary reflexes should be integrated by a trained professional before addressing amblyaudia. And I must say that after years and years of being an audiologist and working with auditory processing disorders, I am so sure that these primary reflexes need to be addressed because they are the underpinnings of the higher levels of development. If you don't have a strong base, information is just going to keep caving in. We won't have even learning. It'll be very uneven. It'll be very frustrating for the children. So I always look at that first. But the intervention for amblyaudia is usually done by audiologists who have access to something called a two-channel audiometer. And what we do is we have two competing speech signals presented to both ears at the same time, simultaneously. So the child is wearing earphones, they're in our booth, and we put one speech signal to the right ear and another speech signal to the left ear. And the child has to either repeat both signals, or they have to listen to one ear and inhibit the other side. So whether we're doing binaural integration, which I don't think you can see my hands, but integration, where we're listening with both ears simultaneously, or we're doing binaural separation, where I ask you just to listen to one ear or the other, it still works the same area of the corpus callosum. And so what happens is the target ear, let's say the left ear is weak, so the left ear would be our target ear, would hear the signal at a comfortable volume or a comfortable listening level. And the non-target ear would have to be at a lower signal in order for the child to be able to hear this one over here. If they're at the same signal, the child says, no, the right ear is louder, I can't hear the left side, so I have to turn this signal down. And then over time, we work on these dichotic listening tasks, and little by little, we keep increasing the volume on the right side until the volume level is the same in both ears, and the child can hear and understand both signals. Programs such as ARIA, CapDots, and the DID procedure are similar, and they use all of the techniques that I've just described, and we use all of the above at Brainchild Institute. How long does it take for the intervention for amblyaudia to be effective? That's what parents often want to know. How long is this going to take? Am I going to be doing this for years? Is it going to last? How does this work? I will tell you that for many years before these techniques came out, about maybe 15 years ago that people started using these types of techniques and experimenting with them, we didn't really know how to treat these types of problems. We would give all kinds of strategies and recommendations and ways to kind of skirt around the problem, but it really didn't directly address the problem. And the exciting thing is that we can now directly address this problem. We can completely correct it in some cases, in many cases, I should say. So most of the kids at Brainchild Institute are finished with their training for Amblyaudia within 5 to 6 weeks, very short term. They attend training once a week for an hour or twice a week for 30-minute sessions. Then we repeat the dichotic listening tests after the intervention to see how they've done, and again at 3 months post-intervention to make sure that the child's dichotic listening skills are maintained. In our office, at least 85% of the children maintain their levels of achievement after 3 months. If there's a regression, a few booster sessions may be needed, with another 3-month follow-up after that to make sure that the results are holding. So what results can parents and teachers expect after completing intervention for Amblyaudia? Here's a very short list. Number 1, improved listening comprehension. The kids are finally getting it. We don't hear them so much saying, I don't get it, I don't get it. What am I supposed to do? We're stopping, looking around to see what all the other children are doing before they begin their work because they simply just don't get it. So improved listening comprehension is top of the list. Better reading comprehension as well. I just had a little girl the other day came running in with her reading comprehension test and an 89 on it with the biggest smile. She had 89%, and it was the first time ever that she ever got a score like that on a reading passage, and her mother was beaming, and this is only after about 3 weeks of training for Amblyaudia. We also find improved ability to follow directions. You know, many of these children have trouble processing and following multi-step directions, and so all of a sudden you just connect the wiring for them and they light up like a Christmas tree. They have greater confidence in their listening and reading skills, and teachers tell us that they're raising their hands more and they're participating in class discussions much more. Another thing which is hugely important for children of all ages is that they have better social skills. They finally understand when people are joking. They start to understand humor and sarcasm and subtle nuances in speech that they just didn't understand before and took very personally. I'd like to thank you all for listening to this presentation on Amblyaudia. I hope you found it informative, and if you have any questions, please feel free to reach out to me at Dr. Light at brainchildinstitute.com, and I will try to answer any questions that you may have or send you additional information if needed. I hope, again, that this session has been informative for you, and I look forward to your questions. Please give me about 48 hours to respond, and have a wonderful day.